Hello all and welcome to my lecture. My name is Nicholas Zerilli. I'm currently a medical student at St. George's University School of Medicine. And I wanted to talk about radiographic imaging of associated neoplasms in neurofibromatosis 1. And so before we begin, hope you guys like my color scheme here. It's kind of like black and white. It reminds me of X-rays and CTs, perfect for radiology presentation. Okay, so neurofibromatosis 1, also known as von Recklinghausen syndrome, is one of the most common inherited CNS disorders, autosomal dominant disorders, and inherited tumor syndromes. It's one of the neurocutaneous syndromes. Also included is like von Hippel-Lindau, tuberous sclerosis, and neurofibromatosis 2. The etiology is a mutation in NF1 gene, which is located on the chromosome 17q11.2. This gene locus encodes neurofibromin, which is a GTPase that deactivates RAS GTP, essentially acting as a tumor suppressor. And this kind of results in numerous different types of tumors in patients with NF1. Epidemiology, you can see 1 out of 2,500 to 3,000 people getting NF1. And clinical features include such things as these skin changes such as cutaneous neurofibromas, cafe au lait spots, axillary inguinal freckling, and miscellaneous findings such as Lynch nodules, sphenoid wing dysplasia, and pseudoarthrosis. So the diagnostic criteria for NF1 was just recently updated, and it follows these features, and you just need 2 or more to diagnose NF1. So you have 6 or more cafe au lait spots, and when you're prepubertal, it has to be greater than 5 millimeters. When you're postpubertal, it's 15 millimeters. There's also freckling in the axilla, 2 or more fibromas, neurofibromas, 2 or more Lynch nodules, optic pathway glioma, or osseous lesions that are distinctive, apparent with NF1, or a gene variant of NF1. And these skin findings have to be bilateral to acquire the 1 of 2 clinical features. So now we're going to see a representation of external features that a physician like a pediatrician or a primary care physician would see, and then maybe look into diagnosing NF1. So these contain, cutaneous neurofibromas, the classic nodules that you see scattered throughout a person on the skin, and these can be large or small, and these are just benign lesions that are from neurosheath tumors. We also have the Lynch nodules, which are also called iris hamartomas. You see these little dark nodules. These are benign hamartomas inside the iris that are benign, nothing to worry about, just kind of aesthetically weird looking. Cafe au lait spots is the next one. So these are just essentially macules or papules on the skin scattered throughout. We see about like 7 here. And also, yeah, these are all diagnostic criteria that we mentioned on the first slide, or the slide before this one. So now we're going to go into the neoplasms associated with NF1. And there's a lot. This list is not all inclusive, and it can be various, and you can have multiple of these at the same time. So we have neurofibromas, malignant peripheral nerve sheath tumors, which are the malignant version of neurofibromas, pheochromocytomas, Wilms tumor, rhabdomyosarcoma, renal angiomyolipomas, sarcoid tumors, leiomyomas, and various types of gliomas. And then we have leiomyosarcoma and gangliogliomas, and then some leukemias. So today we're not going to cover all of these. We're going to cover a certain subset of these and just the most common ones that you might find in an NF1 patient if they were to have them. So we're going to start with the neurofibromas. So neurofibromas are benign peripheral nerve sheath tumors, usually solitary or sporadic. However, there's a strong associated with NF1. These are mostly indolent tumors that rarely undergo malignant transplantation. And when they do, they turn into the NPNST malignant subtype. And this is only really seen in large fibromas. And if there is one, then it only occurs in like 5 to 10% of the tumors of the neurofibromas. So strong association with neurofibromas with the NF1, and they can turn malignant if they get large enough. So growth pathology of neurofibromas. We see that this little growth here looks benign. It's well encapsulated. No undifferentiation, well differentiated. No necrosis or hemorrhagic features here. So we're going to move on to our first case of neurofibroma. Case 1, so 30-year-old male with a right neck pain. So neurofibromas on CT should be well-defined in hypodense mass. They should have minimal or no contrast enhancement. And so we see that here on CT, we see when comparatively looking at the left and right side of the patient, we have a huge mass in the carotid space, protruding up towards the jugular foramen. This mass invasive lesions inside the bone. So moving forward, we're going to go to our next case, 50-year-old male with a low back pain and right lower limb numbness. So this is neurofibroma again. We're looking at a non-contrast CT. So we're about the level of T11, and we can see our liver, our spleen, pancreas, aorta, IVC. You can see our left kidney here. And then we see a mass coming out from the spinal canal. It seems to enwrap the vertebral body here and push across the cruce of the diaphragm. And we see it ends up, or comes out of the dorsal column in the spinal cord, and has relatively hypodensity with a little bit of increased density here. This is characteristic for a neurofibroma coming from a spinal cord, being well encapsulated and relatively homogeneous. So moving forward, we're going to talk about the MRI features of neurofibromas. So T1, we're looking at hypointense. T2 should be hyperintense. When we add contrast on the T1, we should see a heterogeneous enhancement. So case 3, we have a female whose MRI was recommended by a radiologist due to mass found on CT. And so we start with the axial T1 here. When we're looking at the axial portion, we can see the muscles here. We can see the vertebral body, the retroperitoneal space. We see the psoas muscles. And then we see like a little mass here that seems to not fit in with the muscles. It seems to be isodense with the psoas muscle. But when we move to T2, we can see that this mass is relatively hyperintense with a central hypointensity, and seems to be coming from a nerve root here associated with L3. And this is what's called the target sign. So we see it kind of looks like a target with a central hypointensity and peripheral hyperintensity, kind of denoting that this is like a central portion of like stroma, and then the periphery is maybe like a watery type of substance. So case 4, we have a 30-year-old female with NF1 diagnosis. Radiologist recommends MRI for diagnostic evaluation after discovering nodules throughout the body on CT, the largest being in the left lower limb. So when we look at axial T1, we can compare the right and left legs. We see that the left leg is much larger than the right leg. And we see that this mass seems to be isodense with the gastrocnemius muscle that it's inside of. And when we move to T2 spare, where we decrease the fat intensity, we can see some big tumor hyperintensity, relatively heterogeneous with some edema, kind of lobulated, definitely out of place here. And this tumor was actually found to be in part of like the tibial fibular nerve bundle. And then we see, this is not axial, this is supposed to be sagittal portions of the same tumor. And we can see it's isodense here, again on T1, and then hyper intense here on T2. So differential diagnosis for neurofibromas is actually going to be the next topic we discuss, which is going to be malignant peripheral nerve sheath tumors, the malignant version of the neurofibromas. So NP-NST tumors can either rise de novo or dedifferentiate from existing neurofibroma, most often plexiform neurofibromas, or rarely from neurogenic tumors. NP-NSTs usually arise from large nerve and those that occur close to a plexus. So sacral plexus, brachial plexus, maybe a sciatic nerve, things of the such. NP-NST growth pathology. So this does not look like the benign tumor that we've seen with the neurofibromas. It seems kind of lobulated. It could be invasive, but it is not very like undifferentiated. It seems pretty well differentiated. There's relatively homogeneous lesions here, kind of like pale and gray inside or color. So moving on for the NP-NST, we have case 5, adult male with right leg swelling and saddle anesthesia. So on CT, we should be looking for a classically ill-defined hypodense mass. And when we look over here on the axial portion of our CT in the pelvis, we see a large mass protruding from the anterior side and also the left side, but more right side. And it looks to be invading the psoas muscle and pushing away parts of the intestines and parts of the iliac vessels here and here, and seems to be invading some bone in the sacrum as well as the ilium. If we look at the coronal portion, we can see that it is going up above the blade of the iliac and invading the gluteus muscles, and it's also going down and causing some mass lesion and occupying some space, pushing other things away. And this is an ill-defined hypodense mass. It's somewhat heterogeneous, and it looks pretty malignant. So case 6, a 40-year-old male with abdominal pain. Again, NP-NST, we're looking at a T1, usually iso-intense compared to muscle, and then T2 is hyper-intense, but can have heterogeneity due to high collagen content. So T1 over here, we can see that it is hypo-intense, more hypo-intense than the muscles we say here. It's heterogeneous and very large in this case, pushing away our IVC or aorta here. And then on T2, we can see a heterogeneous mass, pretty hyper-intense. Yeah, heterogeneous in size, or heterogeneous in color and relatively large in size. So when comparing NP-NST and neurofibromas, we have a little chart here that helps us kind of really differentiate what's going on. And schwannoma is actually included in here because it's actually a differential for both neurofibroma and NP-NSTs. So moving down here, of course, the lesion location. Both schwannomas and neurofibromas are most often seen in the head, extremities, torso, retroperitoneum for the schwannoma. NP-NSTs are mostly seen in major nerve trunks. So like we said, the plexuses. And then the mass-nerve relationship, all these are going to be in the central relative to the nerve. Capsules, so schwannomas usually have a capsule 70% of the time, neurofibromas 30% of the time. NP-NSTs are very rare to have a capsule. The target sign, which we're going to discuss next, schwannomas 50% have them, neurofibromas 50 to 70%, and then NP-NSTs don't usually contain that. Fascicular sign is common within schwannomas and neurofibromas, and we're going to talk about this next as well. Schwannomas usually have cysts, while the neurofibromas and NP-NSTs don't. And then the margins. So schwannomas and neurofibromas, they're very well circumscribed, while NP-NSTs may be circumscribed, but can also be irregular, as we've seen on CT. So the target sign and fascicular sign that we just talked about in neurofibromas and schwannomas can be appreciated on MRI. So on T1, T2, and T1 FATSAT, we can see lesions here, kind of denoting a target. And as we've seen before, we have like a peripheral hyperintensity and a central hypointensity on T2. And these can be well appreciated on T2 and T1. And this is essentially due to the stroma in the central core and the less stromal components on the periphery. The fascicular sign essentially means like muscle, looks like muscle. So these three images here do kind of resemble some muscle here, and they are also due to like stromal differentiation and how it's aligned. And these are going to like really point towards a neurofibroma or an NP-NST tumor. And that's kind of like a big thing to know about, to differentiate the two. So moving on, we have a pheochromocytoma. So pheochromocytoma, they're a tumor of the adrenal gland chromaffin cells. They are associated with numerous syndromes such as tuberous sclerosis, MEN2A, MEN2B, NF1, and numerous other syndromes. And it follows the rules of 10 classically. Ideally, it doesn't really. 10% of extrarenal, 10% are extrarenal origin, such as the organ of Zuckerhandel, which is at the bifurcation of the aorta. 10% are bilateral, 10% are malignant, and 10% are found in children, and 10% are familial. So gross pathology, we can see the adrenal glands superior to the kidney here. And this pheochromocytoma actually invaded the kidneys on this patient and had to be grossly resected and surgery. And we can appreciate that it is relatively heterogeneous. There is some hemorrhaging, but definitely not homogeneous in contour. So case 7, we have 35-year-old female with hypertension and elevated plasma metanephrines. So pheochromocytomas usually on non-contrast CT are usually large and heterogeneous masses with area of necrosis and cystic changes. So when looking at this patient on axial CT, we can see our liver here, we can see our spleen, our pancreas, and then we see a mass here that's not supposed to be there. And when we compare it to the other side, we can see that this is the adrenal gland on the right side, but the left side has a relatively homogeneous mass in the adrenal gland, which contraindicates what the CT usually is. Pheochromocytoma is usually found on CT is usually heterogeneous. This one is homogeneous. And on this patient, they actually did an MIBG scan, which essentially is uptaken by the pheochromocytoma and helps you delineate if it actually is a pheochromocytoma or a neuroblastoma. Both will uptake the MIBG, and this is treatment actually, but you can see if it is well uptaken on this scan, and this helps decrease the size of the tumor. So moving forward on MRI, pheochromocytomas should be slightly hypointense on T1, and necrotic or hemorrhagic features will make this more heterogeneous. On T2, we're looking for hyperintense or a light bulb sign, but 1/3 are negative, so don't really rely on this. In phase and out phase is pretty important in the pheochromocytoma because it helps us delineate other tumors that we're going to talk about. And in and out phases essentially just kind of show if there is a large amount of intracellular lipids. And then T1 contrast is a heterogeneous enhancement for pheochromocytomas. So case 8, a 25-year-old male who's referred for evaluation of hypertension. So on MRI, as we discussed, T1 should be in hyperintense. In this case, the tumor is hyperintense centrally and peripherally has hypointensity, and it's in the adrenal gland. And we can see that because we have our liver here, and the kidney should not be at this level as of yet at T11. And then we have our spleen here, and then our ascending colon. And then T1 in phase and out phase. So essentially should show us some fat. And if there is fat on the out phase, we'll have a signal decrease. And so we see here in phase versus out phase, our tumor doesn't really lose any intensity on the signal. So that kind of supports that there is no fat in here. So that kind of moves us to our differential diagnosis for a pheochromocytoma, which is adrenal adenoma. So as discussed before, the in phase and out phase should show fat. If there is fat, then there should be a signal decrease. And we see that here and here, our tumor actually loses a little bit of intensity of signal. So that supports that this tumor has fat, and adrenal adenomas are known to have fat compared to pheochromocytomas, which do not have fat, which helps us delineate the two. And then on non-contrast CT, we also see the adrenal adenoma with a heterogeneous color, not very large, but definitely noticeable compared to the other adrenal glands on the right side. So moving forward, we're going to talk about the Wilms tumor. So nephroblastoma is a tumor of embryologic metanephric cells, which would later form the renal parenchyma. I say which would later because as a tumor, it has not differentiated into the tubules and to the glomeruli that we know and the kidney. 85% of cases occur in the pediatric population. Presentation is usually due to painless abdominal mass. Wilms tumor are usually large heterogeneous solid masses which displace adjacent structures, and occasionally they may be mostly cystic. So gross pathology. So Wilms tumors they can have many faces. In this study in India, 31 cases at a tertiary center were found with Wilms tumor, and their growth pathology is presented. We can see that there is, like I said, many faces to the Wilms tumor. It could be cystic, it could be hemorrhagic, it could have more stromal components. So we can't really definitely rely on one type of image when we're looking at CTs or MRIs, but definitely well to appreciate here. Case 9, so a 5-year-old female presents with an abdominal mass. So Wilms tumor on ultrasound should be hyperechoic, located in the cortex with possible posterior acoustic shadowing. So this is all the left kidney, and this goes from top to bottom. So here we can see our kidney with a little bit of cortex here, and maybe some renal pelvis here. Moving down, we can see our cortex again, and then our renal pelvis here a little bit. And then we see a large mass protruding from our kidney on the left side. And then moving further down, they could find a hyperechoic mass, relatively heterogeneous, looks like some tubules, maybe some blood vessels are trying to form here. So this patient was referred for CT to better delineate, better appreciate the tumor. So axial CT with contrast was performed and showed heterogeneous soft tissue density, which correlates with what you should find in a Wilms tumor. So I went down with the different levels just to show how big this mass was. So T12 to L3, so T12, we can see the mass coming from the cortex here of the kidney, displacing some intestines. L1, we can better appreciate the mass, relatively heterogeneous, very large in size, pushes the aorta across and squishes some intestines and other structures inside the abdomen. And then as we go down further, we can just better appreciate the mass and the heterogeneity of this mass. So on this patient, since they did a whole body CT scan, they actually found that this patient, this 5-year-old girl, had metastases to her lungs and her pleura. We can appreciate the pleural metastases here, and we can also appreciate the pleural metastases here, as well as the lung parenchymal metastases on this patient. So case 10, we have a 39-year-old woman was noted to have hypertension and palpable abdominal mass at a routine general practitioner appointment. So Wilms tumor on the MRI, we're thinking of a hypointensive mass on T1. Contrast with T1 should be heterogeneous, and T2 should be hyperintense. So T1, like we said, is hypointense. We have a cystic mass here. T2 should be somewhat hyperintense. We have a cystic mass again, appreciated. And then once gadolinium is administered, we can see a heterogeneous color of the mass. And we can truly appreciate how big this mass is. I mean, it's very large and definitely displacing a lot of structures inside the abdomen, pushing away the IBC, the aorta, intestines, and such. Yeah, so differential diagnosis is a neuroblastoma compared to a nephroblastoma. Both are going to be usually pediatric patients, both with abdominal masses. Except with the neuroblastoma, this is a adrenal mass. So this is going to be above the kidneys, and this is going to help you appreciate and differentiate the difference between the two. On CT, we can see the neuroblastoma here is relatively heterogeneous with a lot of calcifications and also some hypodensities. On T1, we can see that the mass is relatively hypointense, and then T2 is hyperintense with heterogeneous color, displacing some intra-abdominal structures. And so moving forward, we have the JPA, a juvenile pilocytic astrocytoma. So JPAs are considered WHO grade 1 tumors in the current WHO classification of CNS tumors. They relatively have a good prognosis. Up to 20 of neurofibromatosis patients develop JPA tumors within the first 2 decades of life. 60% will arise in the cerebellum. MRI is currently the preferred image modality, which probably won't change. And the 4 predominant imaging patterns of a JPA are going to be a non-enhancing cyst with an intense enhancing mural nodule, an enhancing cyst with an intensely enhancing mural nodule, necrotic mass with central non-enhancing zone, and a solid mass with minimal to no cystic-like structures. And the most common one being an enhancing cyst with intense enhancing mural nodule. So moving forward, we're going to look at our gross image. So JPA, again, we can see a cyst right here, kind of displacing a lot of the cerebellar parenchyma, and we can appreciate the mural nodule here outside the cyst, which seems to be somewhat in the preliminary process of necrosis, possibly some hemorrhaging, and possibly some calcifications associated with it. So moving on to our first case for JPA, a 45-year-old woman presents with breast cancer and has imaging done, which incidentally finds a tumor in her cerebellum. So JPA on non-contrast CT for this patient at least is a hypodense cyst with surrounding hyperdense mural wall. And as we spoke before, there is different types of JPAs and different types of manifestations you will find. So this one is a hypodense cyst, and when we move superiorly on the CT, it was found that there was calcifications in the surrounding wall. So moving forward, next case is a 25-year-old pregnant female with increasing headache. So JPAs on MRI, we're going to go through the different ones. So T1, we have axial and sagittal here. So on the T1, we can see a relatively hypo-intense central portion with a little bit of hyperintensity in the surrounding periphery, possibly a cyst. On sagittal view, we can see that the mass is occupying a large amount of space, but with no hydrocephalus, kind of compressing the fourth ventricle and the cisterna magna, and small herniation of the cerebellum. On T2, we can appreciate that there is a large fluid collection causing edema around the tumor. Again, we can appreciate the cyst in the center. When we add the flare to it to decrease the fluid of the mass, the fluid intensity of the mass, we can appreciate there is a large cystic structure here with some edema that lost their intensity on the flare. So differential diagnosis for a JPA, especially in the cerebellum, is going to be an ependymoma and a medulloblastoma. And so both on T1 and T2, all 3 of these have relatively the same characteristics. They're all going to be hypo-intense on T1 and hyper-intense on T2. In these cases, it seems like the ependymoma is a little bit more hypo-intense or hyper-intense with heterogeneity. And really the only way to differentiate all 3 of these is to get a biopsy and to get a surgical resection of the tumor to definitely give a diagnosis and see the histopathology and genetic analysis of all these tumors. So the final tumor we're going to talk about is optic pathway glioma. So optic pathway glioma is a tumor that arises in the optic nerve, tract, chiasm, radiations, and or hypothalamus. An estimated 20 to 40% of OPG cases occur in NF1 patients. Specifically, ONT, optic nerve tumors in NF1 patients exhibit specific MRI characteristics. They're often bilateral, typically show a double intensity tubular thickening, also reported as a pseudo cerebrospinal fluid intensity signal, and downward kinking of the nerves in the mid-orbit. ONT of non-NF1 patients tend to have more fusiform lesions. And so OPGs are staged by the Dodge classification. The modified Dodge classification essentially just goes, 1 is in the optic nerve, 2 is chiasmic, and 3 is in the tracts. 3 can also include NF1, leptomeningeal or hypothalamic lesions as well. So this is an optic nerve glioma, specifically in the optic nerve. We can see that this is the actual eye of the person, and this optic nerve glioma invaded the person's eye and accumulated a mass amount of space and eventually had to be resected from the patient. But we can see that this is a relatively heterogeneous mass here, maybe some hemorrhaging, some stromal elements here, and possibly some necrosis here intraocularly. So case 13, we have a 3-year-old male with progressive exophthalmos in the last week without a history of trauma or loss of visual acuity. So this is a OPG stage 1A, essentially an optic nerve tumor. And on non-contrast CT, we can see that there is a large mass in the intraorbital space on the right side, relatively homogeneous. And compared to the muscles, we can see that it is isodense. When we add contrast, we can see a peripheral enhancement on this tumor, which kind of helps us delineate it to be a OPG tumor compared to a meningioma, which we'll discuss later. We can definitely see the proptosis or the exophthalmos, this eye getting pushed forward compared to the left eye here. The right eye is relatively more anterior. So the next case, a 2-year-old male with newly noticed left eye proptosis. So this is going to be the MRIs of our OPG tumors. So on T1, we're going to see a hypo-intense mass. And here we see one in the intraorbital space. I mean, it actually goes a little bit towards the chiasmatic optic chiasm. Well appreciated here. On T2, we see a hyperintensity of the tumor. T1 fat sat essentially shows that there is no fat here. There is no decrease in signal. So that kind of supports our glioma hypothesis on this tumor. Differential diagnosis for intraorbital tumors is going to be an optic nerve meningioma. So this is a post-contrast CT. And so we can see a relatively heterogeneous tumor here, very large and somewhat isodense with our muscles, intraocular muscles. Well appreciated on the coronal and sagittal views. But again, this is a post-contrast, and on the glioma, we had a peripheral enhancement, and on the meningioma, we don't have a peripheral enhancement. So this is what supports a glioma over a meningioma. But again, a biopsy must be taken to ultimately diagnose these two different tumors. So in summary, NF1 is a congenital disease which causes a spectrum of clinical findings, hence why it's a syndrome. NF1 is associated with many different types of cancers, likely due to mutations of a tumor suppressor gene. Early recognition of clinical findings in NF1 is imperative so that imaging may be conducted, if recommended, to aid in tumor discovery. Surgical resection and/or biopsy will help aid in diagnosis of the neoplasms. Essentially, if you have a patient with NF1, you kind of want to do some imaging to screen for different types of tumors, especially because they can be malignant and shorten the patient's lifespan and cause, bad lifestyle. And it's very important to get imaging on these patients. And this is not necessarily like a radiologist type of thing. This is a pediatrician, emergency room, family medicine, neurologist that will refer out to radiologists so we can catch these tumors early if NF1 is suspected. So this is like the summary slide of all the imaging that we've just discussed. So the red is what is recommended to do to really screen for these. Some are not usually recommended to be screened for, only if clinical findings are, come up. So in general, T2 is relatively hyper intense for all of these tumors, besides like the NP-NST one. T1 is relatively hypo-intense for all of them, except the NP-NST can be iso-intense compared to muscle, but usually hypo-intense overall. Yes, and then CT for all of these is various. So neurofibromas is relatively hypodense and well-defined. NP-NST is ill-defined and hypodense. Pheochromocytoma is heterogeneous. Wilms tumor is also heterogeneous. JPA, as we discussed, is category dependent, depending on what type it is. The CT will vary. OPN So we're looking for like a fusiform asophytic mass. It's usually isodense with surrounding muscle. Ultrasound was not diagnosed or not discussed here, but only for Wilms tumor, which is usually a hyperechogenic mass. And then, yeah, brain tumors, we can't really use ultrasound. So these are my references. Thank you. And if you have any comments or questions, I have some memes here for good laughs, if you guys appreciate those.